Good morning, everybody. Good morning, everybody. Good morning. Ah, okay, that's better. Thanks for coming this morning. We're going to talk about falls and your role in preventing falls. It's a really important topic. You all have a role to play in fall prevention. So we're going to talk about the different pieces of it this morning and things that I want you to think about and to document in terms of the things that you are thinking about and looking at when a fall happens. So I have data that we're going to go through that's going to be specific to the Mennonite home. How many people here are peer reporters? Several. Okay. The data comes from our peer reports. When we ask you to fill these out, we're looking at them on a number of levels. We look at each individual report, and our expectation is that the loop is going to be closed in each report. In other words, that we're going to figure out how and why did the resident fall, and we're also then going to hopefully be able to put a successful intervention in place to determine how to prevent that fall. And if we can't prevent the fall, because we can't guarantee that people aren't going to fall. Sometimes we have individuals that are frequent fallers. The goal would then be to mitigate or minimize the number of falls that an individual may have, as well as mitigate or minimize the harm that can result from a fall. So the data that you're going to see is pulled actually from our peer reporting that we do throughout the year. And what you'll see in the data today is the most recent data. So it goes from November 1st of 2017 up through October 31st of 2018. So up until just a couple of weeks ago. So it's really the most recent things that you'll see. And it might interest you about to see how and where our falls are happening, what times they're happening, things like that. We'll also talk about the issues that falls can cause, the risk factors for falls, how we minimize those risks, how we investigate when a fall happens, and again, how we document what we've done. Okay, so let's get into some of our data. So the first report that you see here are events that occurred in the Mennonite home by type of event. So the interesting thing here is that this big blue, that's actually right up here. Those are skin events. 62.3% of your events in the last year have actually been skin tissue events. Falls are all the way down here. 229 of the events, the next highest percentage of falls, but it's all the way down at 14.9%. So that would say probably, if you looked at that, wow, we're doing really well. We don't report that many falls. Although, again, that's 229 for the last year. But we have different ways of measuring the falls that happen that we'll talk about. Does that surprise anybody, that the skin events are so much higher than the falls? No? Okay. That's unusual, by the way, for a nursing facility. Most of our other ones, the highest percentage of reported events is a fall. Okay, so these are the falls in the Mennonite home, excuse my spelling error up there, by essentially what your neighborhoods are. So up here is Dove's Nest. Almost 42% of your falls occurred in the Dove's Nest neighborhood. Followed by your rehab unit, followed by your rehab unit, 68 of the falls down here, and then Northern Lights at about 26% of the falls happen in Northern Lights. So again, and then the rest of them are indoors and the common areas and outdoors. Does this surprise anybody? You work in the facility, I don't. That we have most of our falls happening in Dove's Nest. Does that surprise anybody? What kind of an area is that? Is that long-term care? Okay. Are they around the same size, each unit? What are the sizes of the units?
Dove's Nest is twice as
Okay. And what about Northern Lights? How big is that? Same size as rehab, okay. So these are the falls by specific event type. So the most common fall is from bed, followed by wheelchair, and then unknowns, which is the same as from the chair, and then from then on. I would probably combine this from the low bed with from the bed. So actually, from the bed would really be, 64 of the falls would be from the bed. So let's talk for a minute about this one, the unknowns. I'm glad to see that you have, from the wheelchair and from the bed, specific event types that are more than the unknowns. One of the goals that we have, as I mentioned, is when a fall happens, we have to really try to figure out why and how did it happen in order to attempt a successful intervention to prevent it. You have to kind of figure out the how and the why in order to figure out, well, how can we potentially prevent it from happening, or at least, again, minimize the number of times that a resident falls, or minimize the harm that comes from a fall. So sometimes what I see is that there's a significant number of falls that are categorized as unknown found on the floor. And for example, in Quail Run this morning, we found that the vast majority of their falls were listed as unknown found on the floor. Some of those are genuinely unknown found on the floor. But what I want to emphasize with you is that you don't want to put unknown found on the floor if there is some evidence about how that fall actually occurred. So what do I mean when I say evidence? Well, so if you found a resident in the bathroom and you asked them what happened, and they said, I was on the toilet, and when I got up to button my pants or do my belt, I lost my balance and I fell to the floor. Now, if you found them on the floor, you should not be writing in that one that it was found on the floor unwitnessed. Because again, we have some evidence of how it actually happened. It was, while they were toileting, while they were in the bathroom. If a resident said, well, I was seated in my recliner chair and I dropped the remote, and when I leaned over to get it, pick it up from the floor, I slid out of my chair. We're not going to put unknown found on the floor. We're going to put from the chair, because that's what the resident told us, and we found them sitting in front of the chair. If you are looking at somebody and they're seated in a chair and you turn your back and a moment later you hear, ooh, and you turn around and they're on the floor, what are you going to put? You didn't actually see it. So would you put unwitnessed, I don't know, found on the floor, or would you put from the chair? From the chair, right, exactly. So again, I'm not suggesting that there's a specific known reason for each and every fall. Sometimes it generally is. I don't know, the resident is unable to communicate with me, or the resident says, I was milking the cow and I fell off the bench. And we obviously know that that's not true, right? So sometimes you will have to put unknown. But I want you to think carefully and objectively and think about if you have some evidence that would suggest how they fell. Because again, that is going to help us to determine what interventions might be helpful to put in place if we actually start out knowing, well, how did they actually fall? That helps us to put a prevention in place. Here are your falls by shift. So you have the most frequent time for falls is in the evening shift, but not by that much. Night is a little bit lower, but again, they're really not that far apart. So it's not, sometimes when I run this data, I see that there's one particular shift that is, way up there. That's not really the case here. But again, it's helpful to know when the falls are happening. So now I've broken it out actually by the neighborhoods and, again, the shifts. So the most common looks like for the rehab unit, it's on the day shift. That's when more of their falls are happening. In Northern Lights, it's the evening. And on Dove's Nest, it's the evening. Okay, so what this is showing you are the actual time blocks broken out in 4-hour blocks of when the falls are happening. So let me explain what that means. When you see 1 to 400, it means 1 a.m. to 4 a.m. 4 a.m. or 4:01 a.m. to 8 a.m., 8:01 to 12 noon, 12:01 noon to 4 o'clock in the afternoon, 4:01 to 8 p.m., and this is 8:01 to midnight. These, sometimes you put 0000 when you don't know what time it happened. That's what that means over there. So that's only 2 falls. So again, we can see here is when the most falls are happening. It's from noon to 4 o'clock in the afternoon, okay? Followed by from actually 4:01 to 8 a.m. So what's interesting on both of those is what happens during these 2 time frames. Shift change, right, shift change. So in Pier, you are able, when you're in the system, to drill down. So I could take my little drill, for example, and I could drill down to see, well, here are when most of the falls are happening. What kind of falls happen during that time frame? So that's what I did. I took my drill and I did that. And so this is what I found. 11 of those falls from 12 noon until 4 in the afternoon were from the chair, followed by from the wheelchair. And then the next one was the unknown, which again, we should try, if we could, to get that number down to help us to understand what kinds of falls are actually happening. But here they are. Most of them are from the chair and from the wheelchair during those times, followed by these ones down here. Not nearly as many. When you drill down like this, you're able to, again, get more information, get better information to try to figure out what does that show? Well, it shows that we should probably focus, if we could focus on taking off and chipping away to try to reduce falls, to do a focused performance improvement project might be to say, let's focus on minimizing falls that happen between 12 in the afternoon and 4 in the afternoon. And let's look specifically at how to prevent falls from the wheelchair and from the chairs. Let's start with that and get those numbers down. And that might be a good way to try some specific fall reduction performance improvement projects. I also did a report on the time blocks for the specific neighborhoods. So again, you could see when are they happening. So look at that. That's kind of interesting to me. 12, 12, 12, 12. They're all evenly divided out during those time frames. There's nothing kind of standing out on that. Dove's Nest, again, 23. This is from the 12 to 4 in the afternoon in Dove's Nest. Same time frame for Northern Lights. When you have this specific kind of information, you can be better focused in your attempts to reduce the falls. When you know exactly where they're happening, what time they're happening, you can focus efforts on that. Here are your contributing factors for falls. Probably doesn't surprise anybody. 205 times was noted to be action by resident. This is the top 20, and so the rest of them are all clustered together down here. But the next most common one, again, probably doesn't surprise anybody, trying to be independent. followed by confused or disoriented, and poor judgment. Down here is lost or impaired balance. You know, when you see something like that, are those residents that have lost or impaired balance, are they receiving recommendations to have therapy so that they can improve their balance and their gait? I don't know the answer to that question, but those would be things that you would want to look at. So this graph is showing you, in a benchmarking way, a rate-based way, the true measure of how many falls you actually have. So what we do is, for falls, we collect census data from our organizations twice a year, once in January and once in July. And we recalculate our fall rates. So what you're looking at is two different sets of numbers. This is the group as a whole, and this is Mennonite Village. And these are falls for every 1,000 resident days. So we break out our data to show each licensed area of care. So we break it out, of course, for nursing, and then we break it out for assisted living. So what you're looking at here, again, everything is specific today to the Mennonite home. So you're looking at the falls rate-based data for the Mennonite home. And what you're looking at is the most recent data. I ran your data so that it's showing me from July 1 of 2017 through June 30th of 2018. That's the most recent data. We'll redo it again in January. This is showing you, here is our group benchmark. What this means is that we have all of these various organizations across the country that are in the risk management program. We all define a fall the same exact way. We all report a fall the same exact way. So everyone's being compared on an apples-to-apples basis. We collect the census data from all those organizations, and we then run the data, okay? So what this shows us is that in the group at large, for every 1,000 resident days, we have 8.8 falls. So that means almost 9 falls for every resident days, every 1,000 resident days. Then we break it out to say, well, how many of those falls actually resulted in harm? Most of them did not result in harm. It was severity level 1s. 2.2, so a little bit more than 2 of those falls out of the almost 9 resulted in some kind of harm to the resident. So that is a temporary harm, like a laceration or a bruise, a serious harm, which is usually a fracture or a hospitalization, or death. It's not breaking them into just serious or just death or just temporary. It's lumping them all together, anything that resulted in any kind of a harm to the resident. So you can see that most of the falls for the group and for you don't result in actual harm to the resident. So now compare, how does Mennonite Village and Mennonite Home do compared to the group at large? Better than the group at large. 8.2 for every 1,000 resident days versus 8.8, and a little bit less than the harm rate, 2. For every of these 8 falls, 8.2 falls, 2 of them resulted in some kind of harm to the resident, okay? When you look at this, you are doing better than the group benchmark. So that's something to be proud of. That's something really good. However, what I would say is that even though you only had 14% of your falls, overall, when we looked, you can see that it doesn't equate to like, whoa, you're like way down here and everybody else is way up here. So even though, again, it shows that you had 14% of your, or 15% of your events were falls, you can see that when you look at it actually based on the number of resident days, it's still, it's over 8 falls for every 1,000 resident days. That's still, I've seen organizations that have overall fall rates that are way below the group benchmark, in the range of around 6, a little bit more, a little bit less. I've seen falls with injury rates that are, down low, like could be like 1, 1.5, things like that. So again, don't get fooled into a false sense of security, like, oh, we only have 14% of our events are falls. That's still a significant amount for every 1,000 resident days. It's not that much lower than the group benchmark. You follow? So falls, what I'm saying is that falls are still a significant problem. And falls are still a significant problem because of the litigation risk of falls, as we're going to see. The most common lawsuit against a long-term care provider is a fall with a serious injury. That's what people get sued for the most, organizations. So let's talk about the issues caused by falls. Lawsuits, just like I said. The most common claim against a senior living provider or a long-term care provider is a fall with a serious injury. What else what other issues do falls cause? Citations, deficiencies, and CMPs, or civil monetary penalties, by the state government and the federal government, too, who can survey us, either on our annual survey or for a complaint survey. That's still an issue that we get, and they still come in and they look at all of our falls, and they're asking a lot of questions about our falls when we are getting surveyed. Fall injury treatment costs that drive up the cost of medical care. Injured residents who end up with a poor quality of life. So we know a lot of times that a resident could be basically going along and doing okay, and then if they have a fall with a serious injury especially, they kind of go down off that cliff. We know that a lot of times that really causes them to have a very poor quality of life after they sustain one of these falls with a serious harm associated with it. That, of course, leads to upset and unhappy families, and in turn, that also causes us as staff members to get stressed out, okay? What about the compliance piece? Again, we know that we are surveyed by the regulators, both from the state and it could be also from the federal government. I know one of our communities just had a follow-up survey by the feds when they had a deficiency survey from the state. That happens a lot. When you get deficiency-free surveys or you only have a couple of deficiencies, the federal government wants to follow up right along behind that because they don't really buy into that. How could someone be perfect? They don't buy that. So sometimes when you get a really good state survey, surprise, here comes the federal government up, at your door. So those regulations from CMS and from the Department of Health require that we maintain an environment as free from accident hazards as is possible. It also requires that we provide adequate supervision and assistance to prevent accidents, and of course falls are considered accidents. They require that we emphasize resident-focused care and individualized care planning to each resident, okay? It means, again, that you've got to think outside the box and you've got to look at each individual fall and you've got to individualize your care plans. There can be no one-size-fits-all mentality. The days of saying, someone had a fall, so we're just going to slap, a bed alarm on them or a chair alarm on them, those days are gone, okay? The days of looking at it and saying like, oh, well, older people fall. We can't say that anymore. That's absolutely unacceptable. So let's talk a little bit about the negative effects that falls have on residents. So falls are the leading cause of injury among people that are 65 and older, and that's not just limited to our setting, a senior living setting. That is in general. Anyone that's 65 and older, the leading cause of injury is a fall. The most common serious injury sustained from a fall is a fracture, okay? It's a hip fracture specifically. 1 in 5 elders with hip fractures die within a year of that injury. That's what I said when I talked about, kind of falling off the cliff. Other potential complications that falls cause. Well, when somebody has a fall, they lose their confidence and their confidence in being able to get up, and they become fearful of getting up and moving around. That then results in reduced activity, which causes muscle weakening and atrophy. And then the vicious circle is, now I'm weak, and so that causes me to be at an increased risk of falling again if, in fact, I do get up. So it's this vicious circle that surrounds falls of, now I'm afraid to get up, I lost my confidence because I'm not getting up, I become weak, and then when I do get up, because I'm weak, I fall again. So let's be clear on the definition of a fall. It is unintentionally coming to rest on the ground or the floor or on the lower level, but not as a result of what's called an overwhelming external force, and that's just a fancy way of saying that if somebody gets shoved or pushed, then it's not going to be considered a fall, even if they go to the ground, okay? So if I get shoved by another resident and I go to the ground, it's not considered a fall. But, you know, anytime that I lose my balance and I go to a lower level, so, you know, if I suddenly lost my balance and sat in this chair, that's still considered a fall, okay? When a resident loses their balance and would have fallen if not for staff intervention, it's still considered a fall. It's going to be an intercepted fall. A fall without an injury is still a fall. And we see that most of our falls, right, they don't actually have any injury associated with them. But we still capture it. It's a severity level 1 fall. So unless there is evidence suggesting otherwise, when a resident is found on the floor, a fall is considered to have occurred. There can be rare occasions where a resident is on the floor and it's care planned and it's not going to be considered a fall. And the one that jumps out into my mind is we have had a couple of residents in the past at various communities that were repeatedly found on the floor next to their bed, kneeling. And they were being put in as a fall until they communicated and spoke to the resident and found out, well, actually it wasn't a fall. The resident said, my practice is to pray on my knees next to my bedside every night. If you know that to be the case, then something like that could be care plan. And if you find them on the bedside on their knees against the bed, then that would not be considered a fall. But normally, if we find a resident on the floor and it's not care planned in any way, then it is going to be considered a fall. So, fall risks. There are multiple factors that are combining to create risks for falling. They're both intrinsic and extrinsic. So we're going to go through what they are. When we talk about intrinsic factors, it's things like the physical and mental abilities and the cognitive conditions of a resident. Extrinsic factors are related to the environment and to surroundings. Okay, so let's go through some of the intrinsic factors for falling. Anyone that's older than 65 has an intrinsic risk of falling. Again, we know that from the data in general. Are most of our residents, if not all of them, over the age of 65? Yes, probably, right? A history of falls makes you at risk for falls. It's intrinsic. Incontinence or frequency or urgency. Again, how many of our residents have that? Many of them, okay? Lower leg weakness, gait and balance difficulties, use of tranquilizers, sedatives, hypnotic drugs, or antihypertensive drugs, use of 4 or more prescription drugs. How many of our residents take 4 or more prescription drugs? Almost all of them? Yeah, probably. And also, many of them are taking those tranquilizers, those sedatives, those antihypertensives. Postural or orthostatic hypotension, where the blood pressure fluctuates when you sit or stand or lie down. Reduced vision can be caused from glaucoma, can be caused by cataracts. Slow darkness adaptation. Hearing loss, perceptual changes, neuropathy, degenerative disorders of the spine. Functional impairment, meaning the inability to perform basic ADLs. I would say that anyone who's here, they're not able to do their ADLs on their own at this point. That's why they're here. Changes in mental status, which could include delirium, which a lot of times those people that are going to your rehab unit, those post-surgical people, they can have delirium after a surgical procedure. It's from the anesthesia, and a lot of times that's not recognized. Dementia, depression, sundowning, foot disorders, poor impulse control, belief that asking for help is inappropriate. Those are all intrinsic factors. Let's talk about some of the extrinsic factors related to falling. Bathrooms without handrails or raised toilets. Hopefully we don't have that here. Beds, tables, and chairs that are on wheels. We do have that here. Flooring that is highly polished or wet. That does happen. Loose carpeting or throw rugs. Again, that is something that happens. Cluttered rooms with too much furniture. Or cluttered rooms that have medical equipment like oxygen tubing or other medical equipment, call lights. That can cause tripping hazards. Poorly lit room, ill-fitting or inappropriate footwear, long or loose clothing. People tend to shrink as they get older, and sometimes their clothing is dragging on the floor. Pants or housecoats or dresses, that is a tripping hazard. Poorly maintained assistive devices like wheelchairs or walkers or lifts. Slippery cushions on the chairs or the wheelchairs that cause people to slide out. Slippery clothing or bedding, like silky pajamas or silky sheets. That can cause somebody to slide out of bed. Clothing that is difficult to buckle or zipper or button. This is especially important when you have people that are rehabbing. It's really important to educate them and their families to understand that maybe it's not the best thing for you to be using clothing that requires you to maintain your balance and stand while you try to zipper your pants and button them and buckle a belt or put suspenders on. Maybe that's something that you do in your day-to-day existence, but maybe if you're here, especially if you're rehabbing, it's not really a good idea. Pulling up a pair of sweatpants or lounge pants, or yoga pants for women is a lot safer and easier because there's no buttons or zippers or, clips to buckle. So again, that is something really important that can be shared with people. That can prevent falls. Beds that are too high, improper fitting mattresses, full-length side rails, monochromatic color schemes or distracting colors. Again, to a person that has glaucoma or cataracts, seeing everything, all the fixtures in the bathroom that are white can be really difficult to discern. It's the reason why, lots of times facilities put the black toilet cover on there. Loud or distracting noises is another extrinsic risk for falls. It can startle people. Miscommunication that occurs between staff, residents, and families. Inadequate staff training and education to recognize what the risks are for falls. Attachment to equipment like IV lines or oxygen. Misunderstood instructions on the use of assistive devices. Refusal to use the necessary assistive devices. Time of day. Again, we saw that earlier, that the two highest times of our falls are also coincidentally the times that we do shift changes. Medications can certainly cause a significant fall risk. So prescription medications and even over-the-counter medications that increase the risk of falling include antiarrhythmics, antihypertensives, diuretics, laxatives, neuroleptics, non-steroidal anti-inflammatory agents, oral hypoglycemics and insulins for those who are diabetic, psychotropics, sedatives and hypnotics, antidepressants, vasodilators. How many of our residents are on one or more of these medications? Just about every single resident. At least on one of these medications, if not multiples. Working with your pharmacy consultant can be really important because sometimes these people have been on these medications for years and there may not be a reason as they're aging to keep them on those medications. So it's really helpful to talk to the pharmacy consultant about potentially weaning them off of the medications, lowering the doses of those medications. Do they really continue to need all of those different medications? If they're, again, is the benefit of those meds outweighing the risk of the falls? Those are things that a pharmacy consultant can really help with. Proactive fall prevention includes rounding in a resident's room. Now, a lot of times, staff are somewhat resistant to rounding, but proactive rounding has been really shown not only to decrease falls, but to also decrease the use of call bells, which is what keeps staff members running constantly during their shift. Whereas when you proactively round, you go on an hourly basis into each resident's room and you ask them specific questions. It dramatically cuts down on people using their call bells, and it also decreases falls. So when you're rounding in a resident's room, offering toileting assistance is an important proactive way to prevent falls. Asking about pain levels and the need for pain medication. Repositioning residents who are in their bed or their wheelchair or their chair. You know, one thing that I often think about, if I were in a facility, would I want to sit in the same spot in a chair like for hours on end? I don't know about you, but I know I wouldn't want to do that. So think about that. People that are needing to be moved and repositioned in those chairs. It causes a lot of you know, irritation in terms of your mood. It can cause agitation, and it can cause boredom and loneliness, and that causes people to want to get up and move. They don't want to just sit in one spot. The same way you don't want to sit in one spot, because it can get really boring. So think about that. Asking if they're hungry or they're thirsty. Asking if the temperature is okay. You know, is it comfortable? Some people like it really cold, some people like it really warm. Again, if it's uncomfortable temperature, it can cause agitation and irritation. Ensuring that they have necessary items within reach, like the landline, their cell phone, the call bell, the remote, the water, the tissues. Okay, so after a fall happens, you then have to investigate. So again, our purpose of investigating is to figure out how and why it happened. The only way to put a potentially effective intervention is to know why it happened. You can't just start throwing, you know, darts at the dartboard. Oh, let me put in a chair alarm, or let me lower the bed to the floor. Just doing like all the typical things. You got to think outside of the box. So again, that's the best way to prevent a reoccurrence. So you're going to look at intrinsic and extrinsic factors, behavioral or functional changes that can result from the fall, underlying illnesses or problems, medications, environmental conditions, adjustments to the care plan, updating the chart, completing your peer report. All right, so again, documentation really is the key. If you do something, you must document it. Understand that if there is going to be litigation, they do not happen right away. They usually happen years after the event. You're not going to recall what you discussed during interdisciplinary rounds years later, unless you documented it. Are you going to remember what you did to prevent a reoccurrence years later? Of course you're not. You're probably not going to remember what you did to prevent a reoccurrence, you know, a week later if you didn't document it. All right? So if you documented these things, you are going to be able to get that. So every single event should show what you did to investigate and determine how it happened. Show you did a deep dive to figure out why did that resident fall. That's where that data really comes in handy, to help you to focus on different areas. You know, it's very challenging if we just say you need to reduce your falls. You know, how do I start to even focus on how to do that, where to do that, where do I start? Well, maybe again, on the times that more falls are happening, on the types of falls that are happening. Put some specific interventions in place to determine how can we stop people from falling out of the wheelchair? How can we stop people from falling out of the chairs? All right? So that, again, requires a deep dive. What interventions were put in place to prevent that reoccurrence? Every event should have at least one documented intervention to prevent a reoccurrence, or at least try to mitigate or minimize the harm that comes from that. So let's talk about how you investigate. You need, again, to think outside of the box. It cannot just be old people fall. That's not flying anymore, okay? How did it happen? What was the resident trying to do? So you're going to be ultimately looking for the root causes. So let's think about environmental factors, things like clutter, tripping hazards, lighting, improper footwear or clothing, not using their assistive device. Where is their assistive device in relation to where they were found? Unsafe acts of the resident. What about pain? When was their last dose of pain medications? Maybe they're in pain, and that's why they weren't able to sit still or why they felt the need to get up. What about over-medication from pain? What about too much oxy or any of the other things that we give for pain? Those things are serious causes of falls. So again, communicating with the pharmacy consultant, what can we do to reduce maybe the amount of pain medications, or have pain medications that are not going to be such a significant fall risk, like getting people off of oxy. What was the resident trying to do? Were they maybe trying to toilet themselves? If they are, think about the toileting plan. When was the last time that the resident was toileted? Okay? Maybe doing a bowel study. If somebody, we just went through one where the resident, almost every single time that he had a fall, he also had an episode of incontinence. And when we looked at the medications he was taking, the medications that he was taking was causing, one of the side effects was, having urgency for bowel movements. Well, the guy was getting up because he felt like, oh my God, I gotta go. And, it's like, I gotta go now. And so, no time, and he kept falling, trying to make his way to the bathroom. Hungry or thirsty? Again, asking, when was the last time they ate or drank? Is there water or other liquid readily available and within reach? And think about something else. What about the temperature of the water? Some people don't like ice water. Do you ask them, what is the temperature? I happen to have sensitive teeth, so sometimes I have trouble drinking ice water. So again, you want to think about things like that. If the person doesn't like ice water, then make sure that they get water that's at room temperature, so that again, they don't feel the need to have to get up on their own. And that's another reason why you would do proactive rounding. Do you have everything that you need within reach? Everything is there. Are they restless? Think about how long they've been in that area, like we've been talking about. Are they bored? Are they engaged in any activities? Are the activities meaningful? That's something for our activities people to think about. How much bingo can somebody play? Meaningful, engaging activities that are going to stimulate somebody. If you say, I've seen many times in charts, the resident doesn't like to engage in activities. That may be true, but one thing that I'm going to say is, okay, what kinds of activities are you offering? Maybe the reason they don't want to engage in activities is because they think your activities are boring. Okay? So how about some meaningful, engaging activities? What about, again, temperatures? Too hot, too cold? Comfort levels? What about the noise level? Noise levels can be irritating. If it's loud, people can get startled, and that could cause a fall. Are they agitated? Are there roommate issues? And think about, again, roommate issues. I like it really warm. What if my roommate likes it really cold? Is that an ideal situation for two people to be in the room when they both like totally, different temperatures? Because if I'm comfortable because it's a good temperature for me, that means that probably my roommate is really irritable because it's uncomfortable for them. Okay? So again, thinking about, is something bothering the resident? What about family members that have disagreements with their loved one? Be on the lookout for that. When you know that there is a family member that agitates a resident, that every time their family member leaves, they're agitated and they end up falling. So can you stop that family member from visiting? No, probably not. But if you're aware of it and so-and-so is leaving and let me go make sure that that resident is okay and that they're not really upset and agitated, and if they are, I'm going to have a special focus on them for a while until they calm down. Know about things like that. Again, that's really what I would consider to be the personalized care planning. Was that call light on? Are your call light answered timely? How do you define the parameters for timely? What's timely? 5 minutes, 2 minutes, 10 minutes, 20 minutes? 20 minutes, I don't think is timely. But how are you defining the parameters for a timely response to a call bell? What's timely? And what are you doing? Are you keeping the response times? Do you maintain records? Do you have records on that? Are you maintaining them? What are you doing with those records? Are they looked at in QAPI? Are they looked at on a quality standpoint? And what are done? What do you do with those records after the review? Are you keeping them? That could be problematic. You getting rid of them after you've put an intervention in place? Think about, again, what the resident is wearing. Those slippery pajamas or slippery bedding. Clothing that's too long, like we talked about. Footwear. Think about worn out, slippery soles on people's slippers or shoes. Open backs on slippers. Little wedge heels on slippers or shoes. Are they barefoot? That could be a tripping hazard, especially if the floor is, kind of polished. What about women who wear knee highs? I know some of the women, some of our residents, they like to wear those knee-high stockings. Are those things slippery? You bet they are. Are people wearing socks, and do you use socks that have the grippy part on the top and the bottom? Because those things get flipped around, and it's no good if the grippy part is on the top. What good is that doing? Think about those things. Look at that kind of stuff. Again, talking about those difficult pieces of clothing when people have to stand. I talked about in the last session, I don't know what you call them, not the hook and eye, but basically like where you slide the clasp, right. I have pants that have a button and they have a couple of those clasps. Guess what? Sometimes I'm like, oh, can't hook this thing. Luckily for me, right, I don't have balance problems, but guess what? If I did, and I was standing there trying to do that on my own, I could easily lose my balance and fall. So again, you want to talk to people about that. Residents have rights, but you want to educate them on the risks and benefits of doing certain things. So maybe if you were able to explain to a resident and or a family member, I know you like to dress, really spiffy, and I know you like to always have, your nice dress pants on with again, that clasp and the zipper and the belt, but maybe now, because of the risk that it's going to cause for falling, it's better if you just use like sweatpants that just pull right up and there are no buttons or zippers or belts. That's about educating people. And again, if they say, no, I don't want to wear that, I don't feel like it's dignified, okay, that's fine. But please, you must document. And you document that you have, again, it's got to be an informed refusal. In other words, that I've explained to them what the benefits and the risks are of each way of doing it. How is that resident positioned on the floor? That could tell you something about how they fell. Lights on or off. If the lights are on, is the area well lit? This room, some of the lights are on, but not all of them. It's not really well lit. All the blinds are closed, okay? If I had low vision, it might be really difficult for me to see where I'm going. Where is the resident's assistive device in relation to where they are? Again, where is that call bell? Is it sounding? How long has it been sounding? What does the resident have on their feet? We've talked about that. Is that resident wearing glasses or corrective lenses? Are they actually wearing them? Is there a pressure alarm? If so, is it on? Is it connected? Is it sounding? Is there a mat on the floor? And keep in mind that mats can really help. Sometimes when we know people fall out of bed, you put a mat on the floor, but mats can also be tripping hazards when people aren't in bed. So think about that. Again, thinking about the positioning of the bed, the condition of the floor. Is it clean? Is it dry? Is it wet? Is it cluttered? Is anything out of place from its usual spot? If the resident fell out of the wheelchair, are those wheelchair locks on? Are they both on, or is only one on? Could the chair have moved while they were trying to sit in it or get up from it? What else should you be doing is asking the resident what happened, right? What they say can be really important. What were they trying to do? Where were they trying to go? Did they use that call bell? Did they ask for help? What can they tell you about how it happened? They can have really valuable information, and it has to be documented too. Think about changes in their routine that could have thrown them off. So for clinical staff, did you take pulse ox readings? Did you take orthostatic BPs? Did you review the MAR for any of those recent med changes? What types of medications is that resident on? Thinking about all those different medications that we talked about, including things like sleeping pills, pain pills, anti-anxiety, antidepressants. When was the last dose of pain medications or sleeping pills? You know, if somebody took a dose of Ambien and they got up a few hours later, used the restroom and fell, do you think that Ambien was probably a contributing factor? Yes. Or a dose of Oxy? Yes. Did you assess for signs and symptoms of pain? Is that resident diabetic? If so, did you find out what their last blood sugar reading was? Could they be, you know, hypoglycemic or hyperglycemic? Did you assess for signs and symptoms of infection, which again can be a risk for falling? Is that resident on an anticoagulant, Coumadin, Lovenox, Plavix, aspirin? Did they hit their head? Did you ask when the last time they ate or drank was? Have you recommended that they go out 911? Was that care plan being followed? When was that last time the resident was assisted to the bathroom? Was that resident able to reach that call bell? Was there a disruption in their usual routine? Are all of your findings and assessment of these areas documented someplace? I don't care if it's in the chart, if it's in the peer report, if it's on the care plan. Okay? It is acceptable to refer to the medical record in peer, but then it has to be documented in the medical records, and audits should be being done to make sure that that is the case. It's acceptable to put that information into peer, either in the brief factual event description or the investigation detail section, and certainly the clinical findings. Is somebody going to be able to pick up that chart and understand what you did and what you covered when you investigated that fall? That's really the goal. So on your documentation, file managers are going to have to add their follow-up actions. So I always encourage get assistance from that person who completed that peer report, that file submitter, so your information is accurate. What they're putting in there is incredibly important. And if you're a file submitter, what you're putting in there is incredibly important. If you don't put the information in there, it is lost forever. We're not going to be able to find out days later or a week later what happened if you didn't document it accurately. So educate everyone who's a file submitter and who's reporting to the file submitters to completely give the right information and fill it out in peer. When you're a file manager, you need to document your investigation in the follow-up portion of peer under work done on file with the appropriate subtype describing what you did, whether that's a meeting with the family or the resident, an investigation, a re-education of the staff, whatever it is. Please do not add a follow-up action of investigation with no detail of what the investigation was. We're not going to know what you investigated. We can't, you know, have a crystal ball and read minds. All right? Others are not going to know what you did. And if litigation occurs, we're not going to be able to know what you did. So put in work done on file investigation, but don't just leave it blank, like here, right? And don't also put in other and leave this blank. What the heck does that mean? What other? And without telling us what you did, how is that helpful? So document what you did, okay? So if it's an other or a meeting with the family or an investigation, document what did you do to investigate? What happened in the meeting with the family? What did you do to re-educate the staff? What do you mean when you say other? What did you do? Document each step of your investigation in peer. Documentation is critical throughout this process. Doing a great investigation is not helpful unless you have documented what you did. If you call to testify years later, you're going to rely on that information. You're not going to have an independent recollection. So make sure that you are documenting. Okay, so does anyone have questions about any of this? Questions?
I have a question.
Sure.
I noticed that falls from chairs and wheelchairs, and specifically from 1200 to 1600. Now, are these falls happening? I know they're broken down between what area the resident is in, but is it broken down further? Do these falls happen in the dining room because they want to get up from their chair and get back to their room? Have they been taken back to their room? They're sitting in a wheelchair. They want to get to bed.
So that's a great question, and the answer to the question is that yes, we can. You know, anything that we collect in peer, we can pull the data from. So Those neighborhoods that I showed you, those are what we call our event locations. And when you put an event location, like you put Dove's Nest or rehab area, there's a second drop down underneath that will say location. So that would tell you where in that unit it happened. So if we took the little drill, or if I just did a report on, instead of event locations, I could tell you exactly where those falls are happening. The other thing that you can do is, with Peer, is, if you've got that data up and you're working together as a team, you can drill down on it and you can come up with like a file list that'll say, show me all the brief factual event descriptions of all those things. So we know exactly, if you're documenting the way I've been explaining and you put that information in there, then that's all there, and we can look individually to see exactly what you're talking about. Was it while they were, sitting in the dining room? Were they trying to get up? Was it after they were back in their room? And so those are the things that you can do as a team to start to figure out, why are they happening? Okay, now we know why they're happening. What can we do to change this process so that we don't have that issue, So let's say that a lot of them, I don't know this to be true because I didn't dig down as far as what you're talking about. That's really like the role of the folks here on the interdisciplinary team. But let's just say that I found, by digging down, that a lot of those falls were happening because people were waiting. They needed to be toileted right after lunch. They had the urge to go to the bathroom, and because maybe staff were on break or engaged in something else, they weren't getting them to the bathroom quick enough. And because people had to go, they were trying to get up on their own and falling as a result. Well, to me, that would suggest putting something in place like maybe staggering breaks, or staggering shifts, so that we have more people to take, or changing the role of people to say, let's get more people to the bathroom right after lunch instead of doing this particular task right after lunch. Let's focus on, and let's see, does that bring the number of falls down? I mean, the data is there. The data doesn't lie. So you can always, part of a performance improvement project is to figure out something specific that you're going to do, put the change in place, and then the key is measure after that. Did this make a difference? Did we see a drop? Did it work? The first thing that you try may not work. The second thing that you try may not work. It may be like the third thing that you try, wow, look what happened. It went way down. And so those are things, like I said, like thinking about, just right off the top of my head, engaging residents in more meaningful activities, staggering shift changes, staggering breaks, bringing, hiring a person to have like a dual role, like so that person is a CNA who also works with the activities staff. It's again about thinking outside of the box, but the data is all there. The data is there. So whatever you're capturing, so sometimes you may feel, for those of you who are file submitters and filling these peer reports out, especially on a fall, I'll be the first one to admit that's one of our longer forms, and we have a lot of mandatory fields. And you may sometimes feel like, God, why are they asking so many questions? It takes me a while to fill this form out. Well, now you know why we're asking all those questions. Because anything that we're asking those questions about, we can dig down and get the data. So we could find out, we have a field that says, did this fall occur within 2 weeks of the admission? We're asking that for a reason, because we know that people fall more frequently when they first get here. So we can drill down and find out how many of our falls are happening within 2 weeks of the admission. We have a field that, was this a short-term stay resident, or was this a long-term stay? So again, because we know that there are differences between those types of residents, and they don't even like to be called residents, right? They patients. Why are those short-term stay patients falling? May be very different from why your long-term care residents stay. Sometimes the short-term stay, the subacutes, they are pushing themselves because they're like, I'm going to get out of here and I'm going to show them how good I'm doing. So I'm not going to use that call though. I'm just going to get up on my own and show them that I can get to the bathroom by myself, or get dressed by myself, or do whatever. So again, they're different reasons. So that's the reason why we ask a lot of questions and why we have a lot of mandatory fields in those forms, because they're relevant to figuring out how and why are people falling and what can we do to prevent them from falling. Does that make sense? Other questions? Okay, well, we're done. Thanks so much. Appreciate it.